Good morning and welcome to the Florida Health Grand Rounds. We are excited to welcome Dr. Cogle today. Just a few things before we get started. All phone lines are muted, so please enter questions into the question box on the control panel. We will have time for Q&A at the end of the presentation, and I will monitor questions throughout. For those of you who would like to receive continuing education credits, this has been approved for nursing credits. All you have to do to get that is complete the survey that will pop up at the end of the presentation or the survey that is sent in the follow-up email either later today or tomorrow. You do not need to complete both surveys, just one is fine. And then today we have Dr. Christopher Cogle presenting. He is the chair of the Florida Cancer Control and Research Advisory Council, as well as a professor of medicine at the University of Florida.
Thank you very much. Thanks to the Secretary of Health for the invite to present today. My name is Chris Cogle again, and I'm going to present today on the Florida Cancer Plan. I'm presenting from the Alachua County Health Department, and I want to say hello to all the other health departments throughout the state, and thank you for the work that you do. My disclosures is that I'm a faculty member at the University of Florida. As a faculty member, received research funding, clinical revenue, and teaching credit. Also, part of my duties is to work at the Department of Veterans Affairs at the VA Medical Center in Gainesville. I've also founded 2 startup companies, and this CCRAB, Cancer Council work is voluntary. So to talk about cancer in Florida, first, I'd like to start from the context of the diseases and the health, or diseases that we try to prevent and treat, as well as the health that we try to promote. So the top 2 leading causes of death in Florida and in the U.S. is heart disease and cancer. Now, on this slide, I've also shown to you, just as a context, where influenza is. It used to be a leading cause of death, but isn't now. So if you look at the heart disease, age-adjusted mortality rate, and you look at cancers, age-adjusted mortality rate, as well as influenza, where I put a dot is where the zenith is, where the most amount of disease is. You can see that in heart disease, it was in the 1960s. In cancer in the U.S., it's been in the 1990s. And in influenza, it was the early part of the 20th century. Now, a big influence in heart disease and cancer has been tobacco. And you can see what the lead time is between tobacco and heart disease and the lead time to cancer as well. So it's a much longer lead time with tobacco and cancer. Now, influenza in the light blue, here you can see, has gone down for several reasons, hygiene issues, but also in the 1940s and 50s, we started using Salk vaccines more commonly. And when it comes to heart disease, we've had major advances in, first of all, tobacco prevention and cessation. That's been a very big part of reducing the burden of heart disease in our state, as well as learning the effectiveness of aspirin, the importance of cholesterol control, blood pressure control, understanding diabetes and its control, and then the interventional and surgical interventions of coronary arteries. So those have led to just dramatic decreases in heart disease. Interestingly, my cardiology colleagues at UF will point out that we're actually going into a plateau phase for heart disease. And so there's a lot of cardiologists that believe that we are at our pharmacologic and surgical limit of what we can do in heart disease, and that's why there's been a big push to start using cellular therapy, stem cell therapy for heart disease. Now, as interesting of a topic as that is, what today's main topic on the Florida Cancer Plan is this area of the cancer curve right here. Why has that not budged as much as heart disease, influenza, and has there been any improvement whatsoever? And so let's dig deep on this. So if you look at the mortality rate in the last 14 years, for cancer in the United States is in green, and in Florida, you can see is in dark blue here. Now, the rates of death are going down from cancer. And the top reasons why they're going down is, number one, tobacco prevention and cessation. I think this is probably the 8th time I've mentioned tobacco in this talk, and you're going to hear it a lot more. It is the chief carcinogen that we're dealing with in the public. And as you will see, it is a high priority in this cancer plan. Number two is widespread cancer screening. So we now have good evidence for lung cancer, breast cancer, cervical cancer, colorectal cancer, and in selected individuals for prostate cancer. So in those cancers, we've got good evidence that screening can save lives. And so our task over the last 15 years has been to expand access and to increase the number of individuals that are undergoing cancer screening. When you catch people, when you in primary care can catch people in their earliest stage of cancer, me as an oncologist, it's a lot easier to offer treatments that have curative possibilities. And so we rely, this is a partnership, we really rely on our primary care colleagues, the NPs, the PAs, the MDs here in the health departments and throughout the oncology, the primary care clinics to use screening to catch these patients early. The next item in why our incidence rates are going down, the mortality rates are going down, is that we've learned to not give estrogen and progesterone wantonly to postmenopausal women. We know that we need to be very skeptical about who we give it to because those hormones can potentiate really any cancer with those receptors on them, namely breast cancer. And the fourth reason that it's just hitting our mortality rate graph, the fourth reason is that we now have immunotherapies for the two of the most lethal cancers in our state, that being lung cancer and melanoma. So we now have treatments for these metastatic lethal diseases that we had not had before. We are these mortality graphs are just beginning to catch the population benefit that we're seeing with these immunotherapies. So pembrolizumab, ipilimumab, these are antibodies that can wake up the immune system against the cancer. All right. Now, when it comes to cancer incidence, these are newly diagnosed cases of cancer. In the state of Florida, every year, our primary care doctors and NPs and PAs, clinicians, we diagnose over 120,000 patients, individuals with cancer every year. And we estimate that we have about 2 million people in Florida that are cancer survivors. All right, so we have a very large cancer burden in Florida. Now, one of the reasons why our cancer incidence rates have been steadily going down over the past many years in Florida in particular has been tobacco prevention and cessation. Compared to the 1960s, half the adults smoke cigarettes, and there are also fewer youth that smoke as well. It's still a problem, as you will see, but there's less. Now, if you look at this graph, especially the detail-minded people, I want you to notice something on this graph that doesn't look right. And that's on the very far right side. You can see an apparent uptick in cancer incidence. This is not an actual increase in incidence. It is an artifactual increase, and it's actually good news. This uptick is because of the Department of Health improved methods of capturing cases of cancer. So the Department of Health, through a contract with FCDS, Florida Cancer Data System, based in Miami, the DOH recognized that many cases of cancer are not diagnosed in just the hospital, and that a lot of our cancer cases are diagnosed out in the outpatient clinic. And so the DOH and FCDS designed some methods that looked at insurance claims. And they also partnered with outpatient oncology clinics to capture the cases of cancer that may never have to go into the hospital where tumor registrars are based. The tumor registrars are usually in the basement with a windowless office, and they're just going through medical records looking for cases of cancer. They're usually not out in the outpatient clinics. So the DOH invented some new methods to more accurately capture cancer. The United States numbers in green are still hospital-based. And so most likely that green line also needs to be adjusted upward. So we are one of very few states that are doing this new method of case capture, and I want to applaud the DOH for being so progressive and using this new method. We are a beacon for the rest of the United States to follow. Now, what kinds of cancer are coming to our clinics here in Florida? The most highly incident age-adjusted cancer is breast cancer, followed by prostate, then lung and bronchus, followed by colorectal. So those are our top four: breast, prostate, lung, and colon. Where is cancer? So you can look on this map and identify where your health department is situated. And you can see that in the southern parts of Florida, there is a lower age-adjusted cancer incidence. Now, some of that might be because there is more undeveloped land and protected land that are in South Florida. And then what really pops out at you is this I-75 corridor, where they have these orange counties of very high incident cancer. And then also that I-10 Panhandle corridor as well, the Jacksonville area. So there are hot spots or hot areas of cancer incidence that I want you to be mindful of. When it comes to how we compare to the United States, we are in the southern U.S., we are doing very well in keeping down our cancer incidence through tobacco prevention and early detection. But as a whole in the United States, we still have a room for improvement. Now, when it comes to death from cancer, the death rate from cancer, you can see here on this graph that especially in this Big Bend area and out into the Panhandle, we have very high mortality rates from cancer. And this can be because the cancers are diagnosed in late stage. This could be due to access. This could be to care, whether it be through health insurance or lack of health insurance, and many other reasons that are being studied. And as it compares to the United States, as a state, Florida, we are doing well in our cancer mortality. I also want to, because we do so much pediatrics here in our health department, I wanted to point out that with childhood cancers, Florida is doing well. And so in blue is our cancer incidence of pediatric cancers, which is on par with most other states. And in green is the death rate from cancer. And fortunately, as you can see, there is a wide distance between cancer incidence and cancer death. This means that we have a lot of childhood cancer survivors in our state. Now, the cancers where we have a higher, childhood cancers where we have a higher death rate, that being leukemias and brain cancers, we have research programs, new research program here in the state of Florida called the Live Like Bella Pediatric Cancer Research Program. And this is to spur research into these cancers and other cancers and survivorship to elevate the quality of care for our children with cancer in Florida. So this is the backdrop of cancer in Florida is that it's a heavy burden. We are making progress. And we have a legislatively chartered council called the Florida Cancer Control and Research Advisory Council. We call it CCRAB for short. Our job is to advise the Secretary of Health, your department, to advise the governor and to advise the legislature on ways to reduce our cancer burden. We produce, or we help facilitate, a state cancer plan. We also produce every year an annual cancer report, which goes to the legislature to keep them apprised of our progress, but also the burden. And we also help the Department of Health in identifying cancer centers of excellence here in the state of Florida. We're made up of 15 members, and we're represented from cancer control stakeholders from all across the state. So we have spent the last year facilitating discussions, studying the cancer burden in our state, and we've helped the state produce a cancer plan that's just published, and is the reason why I'm presenting today. And this cancer plan is represented here. It has 8 priority areas, and in total, it has 64 objectives that we want to get to in order to reduce the burden of cancer in our state. And what I wanted to point out about this process is that, first of all, this is an inclusive process. So we had town hall meetings throughout the state of Florida. Every cancer control stakeholder, organization, and individual in the state of Florida had an opportunity to read this plan and to provide input at the draft phase as well as in the final polish phase. And I wanted to, and on behalf of CCRAB, I want to thank everyone who gave us their input and helped edit this. It was very many person hours that went into this plan. And again, over the course of a year, so we had plenty of time to have all of these discussions. The other pillar of this plan is that it's built on partnership. CCRAB is not responsible for this plan. Department of Health is not responsible for this plan. The American Cancer Society is not responsible for this plan. This is a plan, as you will see in a minute, that's dependent upon all of us working together. There's no way the DOH is going to be able to do this plan on their own, or CCRAB, or any of the others. So we are all going to have to work together, and I'm going to give you some examples of how we're going to do that. The other pillar about this plan, as you will see in a second, is that the plan doesn't say as granular of information, for example, women aged 21 to 65 should undergo pap smears every 3 years. The plan acknowledges that, but the plan is more focused on what kind of policy changes do we need, or system changes, or environmental changes do we need in order to enable clinicians and individuals to then recommend and undergo those triennial pap smears. Okay, so our focus here is how do we change, for example, your health department? What kind of, in your electronic health management system, your health record system, are there remind systems that could be coded? Rather than just popping up that there's a HEDIS alert, could you actually pop up and see what the actual recommendation is for that individual? Can you do that for EPIC and Cerna, things like that? So it's more focused on systems change, policy change. The other thing about this plan is that there's health equity all throughout the plan, not in its own section. And so when we say we want, for example, women aged 21 to 65 to receive triennial pap smears, we mean all women in all communities of Florida, not just women who have good health insurance. And so we have verbiage of health equity built into the entire plan. And then finally, we have evaluation part of this plan. We want to be able to celebrate when we're doing well. For example, on mammograms in the state of Florida, we have 82% of women aged 55 to 69 who are getting mammograms. And that's fantastic. That is actually above our target that we were hoping to achieve. We should celebrate that because we're catching women with early stage disease and offering them curative options. But there are other areas where we're not doing well, and we want to be apprised of that. So we have evaluation based into this plan. What I want the health department to know throughout Florida is that you have at your resource what are called regional cancer collaboratives. So these are nonprofit organizations that are contracted by the Department of Health to foster collaboration against cancer prevention, cancer screening awareness, cancer treatment in your area. And so I ask for you to look at the map, find out what region you're at. These slides will be made available after this talk, and you are welcome and encouraged to contact your regional cancer collaborative to find out if there's some kind of programming that you could bring here into the health department, or if there's something that the health department could bring out into the community with the help of this regional cancer collaborative. So this is CDC, this is a very large CDC grant that the Department of Health earned several years ago, and with this support from the CDC, these nonprofits are contractually, they are contracted to help facilitate these cancer discussions out into the community. Please use them. And they're a great resource. They're very knowledgeable. They have their pulse on the community. For a matter of discussion, I thought that it would be good if we could just talk about very briefly, four aspects of the cancer plan that I thought are particularly illustrative or something worth of particular interest here in the health department. And let me start off with tobacco. So we've already mentioned how critical tobacco prevention and cessation is to ridding our state of cancer. And so this is a graph of the percentage of Florida youth. So these are high school students that have ever tried smoking. You can see that about 5 years ago, it was around 15%, and it's steadily going down. This is fantastic. This is Tobacco-Free Florida. This is you here in the health department. This is many stakeholders, the American Lung Association here in the state of Florida, American Heart Association. This is all of us working together to work with schools and get the messaging out about the fact that there is no safe level of tobacco. Now, what you'll see in green is a survey question to our high school students here in Florida about whether they've tried any form of a cigarette or a hookah or cigar or electronic cigarette. And you can see that actually ever since 2016, 2017, the ever tried anything is actually going up. And that distance, that splay, is e-cigarettes. We all know that it is an epidemic. It is certainly hitting Florida. And what we're finding out with these e-cigarettes is that the liquid that is being heated and aerosolized and inhaled contains harmful contaminants, in some cases lethal contaminants. I have a fellow at the University of Florida who published a New England Journal article last year that showed a rash of young individuals who were coming to the emergency department with bleeding, parenchymal bleeding throughout their body. And what they had all in common was vaping this substance that had a contaminant in it. It was actually a contaminant that was very much like warfarin or Cogle. And so these young kids were dying and being hospitalized because of this widespread hemorrhage. And so we don't know the long-term effects of this stuff as well. And so the cancer plan calls for e-cigarettes to be regulated and controlled and overseen like we do with combustible tobacco products. Now, in the graph on the right, what we're showing you here is in blue, that's the hundreds of millions of dollars used by tobacco companies in the state of Florida on pro-tobacco advertising. Right? In green is the amount of money that the CDC recommends Florida uses to counteract that tobacco advertising. And in orange, that sliver of orange on the far right, is the amount of money that Tobacco-Free Florida has available to it for anti-tobacco advertising. And so even though Tobacco-Free Florida is doing a fantastic job at driving down smoking rates and smoking cessation, you can see that we're recommended to do more. And they really need more to be able to have a full effect, get to their full potential in eliminating tobacco and getting to the vision of a truly tobacco-free Florida. So in the cancer plan, what we've done is we've split tobacco into 4 subsections. Now, we're here, I'm here with the Alachua County Health Department. This is our health department here with our nice shiny streets, freshly washed, and all of you are sitting in your health department. And what I want to do is shift our thinking here into what can you do to be a part of this cancer plan. So tobacco is one of them. And I'd like for you to think beyond just asking your patients if they smoke, or you can usually tell within the first few seconds of them coming in the room, the smell and other signs and symptoms. But rather than just asking about smoking and making a referral, I want you to think about this on a policy, systems, environment level. That's what we're asking you to do in this cancer plan. So think about on tobacco initiation, on preventing the initiation, how can your health department be a part of your local schools? Are you in your local schools already? If not, is there a curriculum that you can be a part of? Are there children in your practice that are a part of a particular school that you could help with in making sure that anti-tobacco is in their curriculum? When it comes to cessation, don't think about just referring individual patients, but if you're an administrator here in the health department, can you incentivize referrals? Could you call out PAs or nurse practitioners who are making the most amount of referrals? And remember, it takes several quit attempts before actually stopping. And there can be relapses as well. So the number of referrals is a good thing. If you're an administrator here at the health department, have you had a free CME or CEU for your staff? Because all of us clinicians, we need it. We need CMEs and CEUs for our biennial licensure requirements. Could you help provide that at your health department? And you can work with your regional cancer collaborator to make that happen. On secondhand smoke, don't just ask people if they're exposed to secondhand smoke, but could you make a systems change? If there's a questionnaire, can you make sure that your questionnaire asks about secondhand smoke? And then what do you do with that data? How do you act upon it? The next one I want to talk about was cervical cancer. So for several decades, we've used pap smears. Currently, Florida women aged 21 to 65, currently 79% of women are undergoing pap smears every 3 years. Our target is higher than that. What we've learned about cervical cancer is that nearly all cervical cancers are caused by a human papillomavirus, or HPV. And in particular, there's 2 strains of HPV, HPV 16 and HPV 18, which are particularly cancer-causing. So to get to the root of this issue, we've developed a vaccine against HPV, which is best started when both girls and boys are aged 11 and 12. So in their early adolescence, that's the best time in order to teach and awaken the immune system against HPV to prepare them for their sexually active years. So our rate of teenagers being up to date with HPV vaccinations in Florida is only 47%. All right, we're trying to get to 80%, so we have a long way to go, and we need your help. It turns out that our health departments here in Florida are actually at a much higher vaccination rate, and that's because of a lot of the protocols that you and the remind systems that you've developed here in the Department of Health. So kudos to DOH for having that. I want you to be mindful of how your particular clinic is doing. So our goal is a bold goal in this cancer plan. It's the first, we are the first state to come out and say that we are going to eliminate cervical cancer from our state. And the way that we're going to do that is with HPV vaccination. We're going to do pap smear tests, more widespread. And for women who are aged 30 to 65, the recommendation is to do co-testing with a pap smear and an HPV test. So you can actually, you can sample smear the tissue and look for the evidence of the HPV virus. Again, it's age 30 and higher for the HPV test on the cervix. And then we want attention paid to, is there a system change, or is there something in your health system where you can follow up on women that have an abnormal pap smear or HPV test, or in children that don't have the full series of the HPV vaccination? Having these follow-ups are just as important as actually initiating the testing and the vaccination as well. So again, if you're sitting here as a clinician or as an administrator, we want you to be thinking about at the program level, at the systems level. Now, when it comes to colorectal cancer, this is my third of 4 examples I wanted to talk with you about today. With colorectal cancer, about 70% of Floridians are up to date with colon cancer screening. Our goal is higher, it's up to 80%. Now, what we've learned is that many people, first of all, a lot of people in the community don't even realize that they need to undergo colorectal cancer screening. And then they further, if they do know about it, they think that you basically want to do a colonoscopy, which could cause a lot of fear and anxiety in everybody. But there are other methods to do colorectal cancer screening, and actually much less expensive, and even sometimes higher sensitivity. For example, this fecal immunochemical testing, or FIT testing, and now we have the FIT DNA testing, which looks for not just immunochemical evidence of blood, but also looks for colon cancer DNA. That testing can be even more sensitive than colonoscopy. It may not be as specific as colonoscopy, but it's less scary. It's less expensive. The downside of the FIT and FIT DNA is that the FIT you have to do every year, and the FIT DNA you have to do every 3 years, as opposed to colonoscopy, where if that's done and clear, that's done every 10 years. Okay, so it may, in your clinic, of the 3 strategies, the FIT test may work the best because of low expense, or the FIT DNA. Even though it's a little more expensive, the patient doesn't have to come back as often. Okay. So what we're asking for you to do here in the health department is to look at your practice. Is there a protocol that you have for all your PAs and nurse practitioners that your MDs are using? And if not, can there be some consensus about how you're going to do that? are there remind systems that you can create. The Department of Health has periodically, they sponsor a granting program. I know the Alachua County Health Department was a participant in a systems change grant to try to increase the rate of colorectal cancer screening. And the CCRAB is encouraging the Department of Health, and we're full support of the Department of Health to reapply for the CDC grant to do colorectal cancer screening at health departments and other clinics throughout the state of Florida. The last example that I wanted to bring up from this cancer plan, and this is something brand new, no other cancer council throughout or state throughout the United States is doing this, but we agreed as a state to work on 2 high priority cancer fighting campaigns between now and 2025. This is going to be a partnership with CCRAB. We're going to be the facilitators. We want the regional cancer collaboratives to be a part of this. We want the Department of Health to be a part of these campaigns. They're going to be a very important partner, as well as the American Cancer Society, the Leukemia and Lymphoma Society, the Breast Cancer Foundation, the American Lung Association. So we all are going to come together, and we're going to decide on which 2 campaigns. In this question and answer period, I would welcome your thoughts on some campaign ideas that we as a state can work on. When we did our town halls this past year, we heard community leaders talk about transportation is a big issue on getting cancer screening and cancer prevention and cancer treatment services. And so perhaps transportation should be our campaign. We've heard from FLASCO, which is the Florida Society of Clinical Oncologists, that lung cancer screening rates are unacceptably low, and they want to work on lung cancer screening. And this is echoed by community leaders as well. Not a lot of people know that if you're age 55 to 80 and have a 30-past-year history of cigarette smoking, that you should undergo low-dose CAT scan looking for lung cancer. So there's a call to possibly do that. Our human papillomavirus vaccination rates are very low. And in order for us to truly eliminate that cancer, those vaccination rates have to be higher. And so there's a call to that being possibly one of the campaigns. And then we've just talked about colorectal cancer screening. We have a ways to go there. Perhaps that should be our campaign. Are there others that we're missing? In this question and answer period, I would love to hear ideas. And I will pass that on to the rest of the cancer control stakeholders. So there are many other facets of this plan. I encourage you to visit us at this website address below in the coming week or 2. The full plan and all 64 objectives will be published. Currently, we've got the 21 goals that are up there. The rest will be coming soon. And we also have the plan to publish this in Spanish as well, so that it will be fully appreciated by bilingual community or in our bilingual state, or multilingual states. And then you can see here on this list already, there's things we haven't even had time to talk about, like hepatitis C virus. So a lot of our health departments have HIV clinics where we've got an infectious disease expert with us. Hepatitis C is a co-infection to HIV. If you have a health department where you are providing care with the Department of Corrections to your local jail or prison, the incarcerated population is a reservoir for hepatitis C. And there is definitive treatment for hep C that, even though it might be costly, it's nowhere near the cost of the liver cancer and cirrhosis and many other GI bleeding that goes along with end-stage hep C. So with that, again, I want to thank the Secretary of Health for the invite to present the Florida Cancer Plan. I want to thank you for your attention, and I would like you to consider this a call to action. I hope that you found some opportunity on how to bring this cancer plan into your daily work, and I would love to hear from you on your suggestions and ideas. Thank you very much.
So we can start by taking any questions. If either of you have any questions, and then if not, that is the first question that's coming.
Okay. Yeah. Yes.
So I noticed that you have cancer diet and weight management only a dietary plan. What diet and weight? What measures are you doing for that?
Yes, great. It's a great question. The question was, I noticed that you have alcohol. So in the prevention column of the cancer plan, I noticed you have alcohol, diet, and weight. What's up with that? That's the question. All right.
What's the things that you're doing as far as especially diet and weight?
Yes. Okay. We'll start with diet and weight. So there are about 8 cancers that are linked with obesity, and a lot of them are the GI-related ones, which makes a lot of sense. And the objectives that we will be tracking for Florida is looking at the percentage of adults and youth who are overweight and obese. So our objectives are to reduce those percentages of Floridians that meet the criteria for overweight or obese. And in the cancer plan, we have several strategies, suggested strategies, in order to get to those objectives. And there are things like, for example, the youth objectives, as you can imagine, have a lot to do with integrating in the school curriculum. And not just teaching good diet, heart-healthy diets, as my kids like to say, but also teaching the importance of exercise, balancing screen time with exercise, doing screen time that involves exercise. So there's several strategies. The cancer plan just asks you to purposely choose one and champion it for this time being. What we find is that people acknowledge diet and weight, but they often don't. And now I'm not talking about individuals. I'm talking about like clinicians or public health officials. What we want clinicians to do and administrators of the health department to do is to choose a strategy and make it or several strategies, and make it your health department's purposeful effort. So that's a part of the case. And as far as alcohol, what we focus on for objectives is the percentage of adults who have heavy drinking. It's interesting, men, heavy drinking, I forget the exact number, it's going to be in the cancer plan, but the number is like 21 drinks a week. For women, it's like 14. So for women, I guess the strict definition of heavy drinking is a lot more strict. But what we are the strategies that are in the plan are getting at awareness issues, clinicians recognizing heavy drinking. As a clinician, I might ask you to drink alcohol, how many times a week, but I really don't get into the actual numbers. And so, as an anecdote, this cancer plan taught me that I should be asking more specifics, and I should have a trigger. That if they go over this number, then it should trigger me to say, can I talk to you about that? And then can I refer you? I have colleagues that can help with that if I don't have time to talk to them about it. So, and obviously, as this ties back to cancer, it's esophageal cancer, head and neck cancer, pancreatic cancer, colorectal cancer. So the GI, the alimentary canal is what takes the assault from that heavy drinking.
Next, we have a question asking if you can comment on the high incidence of mortality in the Panhandle being related to the lack of access to cancer screening and cancer treatment, and how the cancer plan will address that.
Okay, so the question was back. Let's see, it's back here on one of the early map slides. The question is, what's up with the mortality rate in the Panhandle? And what are we going to do about it? First of all, thank you for the question. This needs to be studied more intently before we make any conclusions about cause. Now, having visited the legislators and their staff who represent the Panhandle and speaking with them about this issue, what I've heard from them and what we are recognizing is that there is a high smoking rate up there. We've also heard from legislators about access to health insurance. Now, I do not have the specific data on insurance, on uninsurance, but also underinsurance. But that is something that needs to be looked at. What's also been positive has been transportation and like the physical access to specialists and to care. So there are specialists out in the Panhandle, some excellent specialists in oncology. There has been proposed that there are transportation issues. Now, I've done research and published it looking at rural versus urban here in Alachua County, and it turns out there really is not a big divide between rural access, transportation access to care, and urban access. Now, but Alachua County only has just its corners having rural corners. It's got a metropolis center. But out in the Panhandle, as we all know, there's some very rural areas, and it should be looked at as you know, what is the drive time between the average patient with cancer and their local cancer screening place facility or their oncologist. So thank you for the question. It's deserving of more study.
The next question is referring to the Florida map list incidence of cancer. They want to know what type of cancers are they and if environmental causes are being investigated. And then their follow-up question is, we have a high population without insurance, so are there any other tracking sources besides insurance claims?
Great question. So the question was on the cancer incidence map, which I'm displaying here in Florida. And so one of the possibilities brought up was, are there hot spots of particular cancers? When we've looked at it, the kinds of cancers that are showing up here in these orange counties are in the same distribution or the same varieties as other counties. And so breast and lung are the top two. Now, the Department of Health does look at clusters of cancer, and sea crab, we have not been alerted to any cluster of cancer, but the department does look for environmental associations. And then the other question was, the other aspect of this two-part question was on the insurance rate. Can you, Edda, can you repeat to me what the insurance question was?
Is there any other tracking source for incidence of cancer other than tracking the insurance claims?
Oh, okay. So, yeah, interesting question. So, yes, so the question is, can you track cancer beyond just using the method of insurance claims? Yes, you can. In fact, I published several years ago a method of we designed a computer algorithm to read electronic pathology reports. So laboratories are legislatively mandated to send their pathology reports to the state cancer registry. And so what I and my team did at the University of Florida is we designed an algorithm to read these reports. And then what we found is we found a lot of uncaptured cases of cancer when you use a computer to read the hundreds of thousands of pathology reports that are sent to the cancer registry every year. So yes, there are other methods.
Our next question is, could you please provide an explanation of the FIT testing?
So FIT testing, since you're asking the question, I definitely want you to look this up. There's a large literature on using FIT testing for colorectal cancer screening. What it does, the essence of it, is that it looks for evidence of blood in stool. And so there are take-home tests that you would give to the patient, and they would have a bowel movement and smear the bowel movement on a card, and then close the card and send it in. And what this testing does is it looks for evidence of blood. Now the FIT DNA test, which is the new test, and is about 10 times more expensive, but it's more sensitive than just doing the FIT test, because it looks for not just the chemical evidence of blood, but it also looks for cancer DNA that's in the bowel movement as well.
And then our other question is, what data source did you use for the HPV vaccination rates in teens on the cervical cancer side?
On cervical cancer slide, so we use TeenVaxView. And in the cancer plan, we list the data source. So in the cancer plan this year, for the first time, for all 64 objectives, we state a baseline rate and its data source, and we also state the target of where we'd like to get to in 5 years. So it's we have referenced every baseline rate, but I believe that the TeenVaxView was the data source here.
That is the last online question we have right now. So
I have one question. This genetic testing that they have online now, the 23andMe, do you collaborate with them on that, or?
Great question. Yes, great question. So the question is how to incorporate 23andMe.com genetic testing, like the direct-to-consumer genetic testing. There's Ancestry.com. There's lots of different companies that do genetic testing. The 23andMe.com is the one that's probably got the most built-up reporting on health. First of all, so anecdotally, I've done it, and it predicted that I will become bald. And for those of you that are not on the call, there's people laughing in the audience because I am bald already. So some of the test results are not very helpful, or they're embarrassing. So now, on a more serious note, there is cancer genetic testing results that are possible in the panel of testing, like the BRCA1 or BRCA2. Those are called BRCA1, BRCA2 for short. So they do report back to you if you're BRCA1 or BRCA2, if you have a variant in those genes. And if you do, then you're at much higher risk of developing several cancers, including breast, ovarian cancer. And for men, they can develop prostate cancer with those gene mutations. Right now, there is no formal and regular linkage between those direct-to-consumer tests and our health system. You raise a good point. I hope, I don't know if Tara Hilton is on this phone call or Gary Levine from FCDS, but I would like to talk with them about whether or not we're incorporating 23andMe.com results. If 23andMe.com is required to report results back to our cancer registry, probably not. It's never come up in the many years that I've been doing health policy work at the state level, but it's a great question, and it's some homework that I'm going to have to do. I will tell you as a clinician that I oftentimes have to repeat the genetic testing because of errors that we've caught at 23andMe.com. So if a patient comes to me and says, my CYP enzyme variant predicts that I'm going to be a poor metabolizer of this drug. You want to prescribe this drug to me. How are you going to use this information? I would first repeat the test because I would want to make sure it's done in a clinically certified lab. So that's how I'm handling it, at the clinic level. At the policy level, I'll follow up on that. Great question.
We have time for one last online question, and they want to know if, in relation to adolescents, are there any studies that say whether males or females are more prone to certain forms of cancer?
Wow, what a broad question. Are males or females prone? Well, males are prone to prostate cancer, and females are prone to breast cancer. But other than that, no. It has to do a lot with your genetics and what kind of toxin exposures that you're exposed to. I will say in closing that tobacco is our chief environmental carcinogen exposure, and the other one is aging, which is very hard to prevent.
And one person just wants to know, for the graph comparing tobacco company and health entity spending, what years does that graph span? So the one you're showing spending.
2016, I think, is the data point, or the data time point on that graph.
And that is the end of our Q&A session today. Thank you all for joining us, and a special thank you to Dr. Cogle for presenting today. Just a reminder that if you want those continuing education credits, they're only nursing credits. We cannot offer medical continuing education credits. To get those, simply complete the survey that pops up at the end of this presentation, or the survey in the follow-up email. They're the same one. You do not have to complete it twice. And that's everything for today. Thank you for joining us.